Hello everyone. So this is a lecture about exercise testing to predict surgical outcome. And so exercise and health and physiology assessment is the fourth population that you may choose to study as part of that. So the outline of today's session is we're going to talk a little bit about the benefits of surgery. So first off, kind of like why would we have surgery in the first place, I suppose. We're going to sort of talk about how surgery is a little bit like exercise. It's kind of parallel between how people respond to surgery and how they respond to a bout of exercise, and how we might want to make use of that. And then we're going to look at something that I did for a long time in hospital, which was using exercise testing to predict the risk following surgery. And then finally, we're going to get to kind of the title, I suppose, which is how these measurements that we typically associate with fitness and exercise can actually be altered by some of the treatments for certain types of diseases, and in particular following chemo radiotherapy. So surgery, to start off with, well, surgery is one of these kind of things where it tends to be a last resort in many cases, but even with that being the case, there's still almost like 5 million surgical admissions each year, or at least until recent years. And these surgeries can sort of range from major to minor. So it could be, say, a hip replacement, which is kind of a moderate one. It might be, major heart surgery, or it could be something quite small like removing your tonsils, tonsillectomy. So that 5 million encompasses everything, really. What we're going to focus on more today is some of the high risk ones. So as you can imagine, depending on the type of surgery that you have, it's going to dictate the level of risk. So this is a paper here just kind of outlining the risk of surgery, I suppose. So on the left hand side is the different types of surgery in alphabetical order, ranging from abdominal through down to sort of vascular surgeries. So you can see these different types. You've got breast surgery, dental surgery, eye surgery, etc. And then this is from a meta-analysis, so you don't really need to worry too much about the rest of kind of the table. But I suppose you could take note of the number of procedures where this data has been drawn off, just so you can understand kind of how big this study, meta-analysis, was. And then finally, on the far right-hand side, you can see the all-cause deaths, or the mortality rate. This is essentially, if you look on the number of procedures, so if we go for abdominal surgery in total, 16,000, nearly 500 people went for surgery. Of them, 606 died, so 3.3%. So that would be considered to be, intra-abdominal surgery is considered to be a higher risk type of surgery. So it's intra-abdominal, they're opening up your kind of abdomen, and they're going to do different types of surgical operations depending on your need. Now, another type of really high risk is vascular surgery. So vascular surgery, you can see in this particular study, is almost 6,000, just over 6,000 people underwent the vascular surgery. 277 of them died, so that's 4.4%. And then if we look at certain types within that, so if we look at acute aortic surgery, so this is usually people who have had a thing like something called aortic aneurysms. And these, if you get rushed in for an aneurysm repair, it can be really dangerous. So you can see in those individuals, the mortality rate is almost 30%. So really, really high mortality rate. And usually that's because it's an aneurysm, which is like a bulging of your vascular system, if you like, your blood vessels. It bursts, which is why you need to go for acute surgery. Because it's burst before it's been planned to be dealt with, if you like, it's a difficult operation to undergo. And then you've got the sort of less intense surgery, so you can kind of see towards the breast surgery and dental surgery. It's still incredibly important, but you can kind of imagine the more external in the nature, so they're not as invasive. You're not going into somebody's chest, you're not going into somebody's abdomen, and therefore the mortality rate in those types of surgery are close to zero. So I suppose the point of this slide really is to show that although surgery is an important intervention, it's an important tool to try and help treat people, there is an inherent risk, particularly certain types of surgery. Now, it's not just about life and death, the risks go beyond that. So we kind of know this a little bit in a minute, because we're talking a lot about COVID. So we talk a lot about COVID and lots of focus is on the number of deaths, but as time sort of progresses, there's going to be more and more emphasis on the kind of morbidity or the long-term health consequences of COVID. And it's the same with operations as well. So this is a study that looked at something largely different than what we're going to use it for. It was looking at a checklist to see whether they could use a certain number of checks to reduce mortality and morbidity in certain populations. And so, but we're just going to look at it just to get some general numbers, just to make the case about how many people are coming out of in the time around surgery, around having surgery, have complications. And so what we've got here is different sites. It doesn't really matter about that, but we've got 1 to 8. These are different locations across the world, and then they've got the before and after the mortality checklist. Again, doesn't really matter to us really. What we want to look at really is that bottom number, so the total, because what that shows us is that in and around about 10% of individuals have some sort of morbidity, some sort of complication in and around the surgical procedure. So post-operative morbidity, so problems if you like. Now that might be a heart attack, it could be a stroke, it could be an infection, it could be all sorts of things, but something that's considered significant in and around that area. So even though the death rates, mortality rates with high rate surgeries are at sort of 3 and 4%, still fairly low I suppose. When you're thinking about major complications, they can come in at around about 10%. So it's a big issue. We want people to go for surgery. It can be helpful in their care process, but some of them are going to die, and some of them are going to have serious complications. So the next question is, well, what can we do about that? Because ideally what we'd love to be able to do is have somebody come in who's not feeling very well, who needs to go for surgery, to be able to run a test on them and then go, okay, based on this test result, this means that you're likely to be one of the people at low risk. So that means we can put you through a normal care pathway, if you like, because you're unlikely to have anything happen to you. And then other people who have the test, I might put them in a different direction, say, oh, this test has now identified you at high risk. So then we might have different options based on that. There might be different discussions about whether the person needs to have that surgery, if it's in their best interest. It may be that they need to go for a high level of care following surgery, so maybe straight to an intensive care unit rather than to a normal ward. Or it might be that the surgery is postponed for a period of time whilst other interventions are put in place to try and reduce that risk. And currently, although it's changing, I shouldn't say currently, historically, the decision about how this was made was done by like an eyeball test. So essentially, the doctor or the surgeon or the anaesthetist who was making a decision about whether this person was high or low risk would have an interview conversation with the patient and just make a decision based on a little bit of medical history and their own sort of guess what they thought that person should be. But obviously you can imagine that's got inherent problems in that it's going to be dependent on the person, the anaesthetist who's making that decision. And what we really want is something that's a bit more quantitative, so we can kind of test it and see whether it holds true or whether it's just somebody's opinion. So this is where this slide's really just to say we need a test. Ideally we want a test to say you're not very well, you need surgery. Are you low risk and therefore you go through a normal care pathway, or are you high risk and therefore we need to take additional measures to try and reduce that risk a little bit lower? Now, a study to look at kind of the big question, like, well, what happens during the time of having an operation that might make people at high risk of having morbidity or mortality? Just sort of paint a picture of some of the things that happen during surgery. Obviously, people are being kind of cut open and being operated on. You might have blood loss and things like that. But there are other more like physiological things that are going on as well. So this study here by Alder and Smith was looking at oxygen uptake. Now, hopefully oxygen uptake is something that you're becoming more and more familiar with. So it's this idea of being able to measure how much oxygen someone's using to get a bit of a sense about what their metabolic rate is doing. So is their body having to work harder on that? And what we've got in this figure here is on the y-axis we've got oxygen consumption, and then on the x-axis we've got different types of operations. So we've got colorectal on the far left, in the middle is abdominal or abdominal vascular, and then the sort of third one along is AAA. This is an aortic aneurysm. It's a vascular problem, and then it's got the average at the end. And then the blue bars are pre-operative, and the red bars are post-operative. So essentially, they've kind of, taken the breath by breath gas analysis that we do, and rather than putting people on a bike, they've done it to somebody at rest prior to having an operation, and then 24 hours afterwards. And what you can see from the figures is that in all of those operation types, there's an increase in oxygen consumption following the surgery. So the body is having to work harder. Metabolic rate is higher following surgery. And that could be for a whole host of reasons, tissue rebuilding and all sorts of stuff like that. And what you've got to remember is this increase in oxygen consumption, which we know is going to start to drive our body to need to respond, is also occurring in the face of a loss of blood, which is going to limit oxygen delivery, and inflammation, which makes the oxygen delivery kind of less effective, if you like. So essentially, this is kind of a physiological problem. The post-surgical phase is almost like mimicking, if you like, a little bit about what we see in exercise. And this is the kind of what was taken from those two people from Older. So Paul Older, the person who did that original study, he said, well, if after having an operation we have an increase in oxygen consumption, which is going to require an increase in cardiac output and an increase in ventilation and all of these things that we see during exercise, well, then actually maybe it's mimicking low-level exercise. So maybe we can actually use an exercise test to learn a little bit more about our patients before they go for surgery. So this is what they were kind of saying, is that the system's the same. It's just what's causing the response is different. If you look at the mitochondrial side, so on the left-hand side, essentially what he's saying is, well, oxygen consumption is going up, which is going to demand we deliver more blood to the muscle, which means the heart's got to work harder, which also means the lungs need to work harder. So what he's saying is, if there's an issue in this, and we can identify it during an exercise test prior to someone going for surgery, well, maybe that can start to give us a hint about what's happening, or which patients might be most at risk, with the idea being that if you've got low ability to use oxygen during an exercise test, then how are you going to fare when you need to increase your oxygen uptake in the post-operative period? So essentially he said, does low fitness equal poor post-surgical outcome? So low fitness is caused by poor cardiac, ventilatory, circulatory and muscular function, overall inability to deliver and utilise oxygen. And we know surgery from his original study demands, or the post-surgical period demands, an increase in oxygen consumption, an increase in heart rate, and an increase in ventilation. So are those with low fitness less able to meet the demands of surgery? And so what he did is he stuck people on an exercise bike, the same ways that we did with you. And he ran a very similar test to the ones that we ran in the lab. So people on an exercise bike connected to a breath-by-breath analyzer, sort of a 3-minute rest period, 3 minutes of unloaded cycling, and then a ramp test to maximal exertion, whilst also measuring ECG just for safety reasons. So he started running these tests, and the outcomes that he was interested in were the similar outcomes that we're interested in. So in particular, this thing VO2 peak is something that we've talked about a lot this year, and that was one of the main outcomes that he was interested in. But they were also interested in a thing called the anaerobic threshold, or gas exchange threshold. And a lot of the research that I'm going to present in a minute focuses on this. We've not focused on this too much with regards to our module, because it's slightly more complicated. Not much really, but I just want to focus on one major thing. And now what's happened since this, what we're going to see is, you might have seen from the heart failure lecture and some others, is that there are lots of other exercise variables that are also important. But in this initial stages, they're mainly just interested in these two. So this is one of the sort of seminal studies in this area. So this is Paul Older, again, a chap from Australia. It's the first study to look at whether preoperative measurements of, he says, cardiac failure and ischemia in patients, but essentially fitness using cardiopulmonary exercise tests could predict surgical outcome. And you can see I split the study design into this kind of PCOS framework, because I want you getting used to thinking about it like this. So who are the patients? Well, it was almost 190 people over 60 years old who were going for major intra-abdominal surgery. He split the group into two. So it's not an interventional study, it's an observational study, and therefore we're looking at an exposure. So he split the group into two. those individuals that prior to surgery had low fitness, and he compared them to those who had higher fitness to see. And his main outcome of the study was mortality or death following surgery. So what proportion of these individuals ended up dying? And the study design was an observational study, and he was looking for differences between groups. So what did they find? So they found, so we've got this, so in this figure, let's sort of like spell it out. We've got number of patients on the Y, and then we've got their anaerobic threshold, so this marker of fitness. And what we can see is that it's been split into 4 different groups. So it kind of works in a similar way to VO2 peak. The higher the number, the better. So in his group here, we've got the I was just trying to see if we'll get a pen on them, but I can't. So we've got on the far left-hand side, those individuals with an anaerobic threshold less than 8 milliliters per kilogram per minute of oxygen. Next one along, those between 8 and 11. Next one along between 11 and 14. And then the far right-hand side are the fittest individuals who had the anaerobic threshold higher than 14 mils per kilogram per minute. And then what we can see in the bars, in the blue bars, it's the people who didn't survive. In the red bars, it's the people that did survive. And what we can see is we're looking at the kind of ratio, if you like, of blue bar to red bar, because that's going to give us our indication of the percentage of mortality within that group. So if we look at the fittest people on the far right hand side, so those with an anaerobic threshold above 14, what we can see is that they all survived. So there was 45 patients, but it was 100% survival in the fittest group. If we go down a group, so it's the sort of like sort of moderate fitness, but on the higher side, 11 to 14, one person died in about 85, 90, so it's a 1% mortality. We go down to the sort of middle low fitness between 8 and 11, they had a 14% mortality in that group. And in those individuals with really, really low anaerobic threshold, below 8 mils per kilogram per minute, it was 50% mortality. I think it was 4 and 4 people, or 3 and 3. So 50% of the people who had a really low anaerobic threshold, so this type of anaerobic threshold, almost you'd be out of breath if you was walking down the street, these 50% of them never made it past the post-surgical period. This is the initial study to kind of show that, well, maybe there is something going on with fitness. Maybe the fitter you are, the better you are doing during surgery. And then this is another way of representing the same data, but just splitting it a little bit more simply. So this is just splitting people according to whether their anaerobic threshold was above or below 11. And those individuals with an anaerobic threshold below 11, there was an 18% mortality. Those individuals with an anaerobic threshold above 11, so the fitter group, their mortality rate was 0.8, so about 1%. So essentially, the fitter they were, the better they did following surgery. Now, I did a systematic review looking at this about 9 years ago, something like that. And all we did is we went through the different data that were out there by different types of surgery. So in this particular table that I'm showing you here, this is mixed intra-abdominal surgery. So this is a lot of bowel surgery. And then we went through the different studies and essentially went to see whether different CPET variables predicted surgical outcome or not. So the different CPET variables were anaerobic threshold, AT, VO2 peak, VEV-CO2, so ventilator equivalence for CO2. Important, something you might want to consider looking at for your assessment. You know, if the literature supports it, have a look at this variable. And then finally, the other variables. And we're not going to go through each study, but what you can kind of see is that in the majority of studies, it showed that the anaerobic threshold was predictive of outcome in intra-abdominal surgery. But what about other types of surgery? Well, in upper gastrointestinal surgery, a little bit more mixed, but in general, it seems to say that VO2 peak and anaerobic threshold seem to predict outcome. And then if we go to vascular surgery, there's a lot less data. Certainly the biggest study in that area certainly supported anaerobic threshold, VO2 peak and VEV-CO2 as an important predictor of surgical outcome. And then finally, there's only a single study looking at liver transplant surgery, which found a positive association between those things. So I suppose overall, what the review showed was that in a range of different types of surgery, your fitness seems to be predictive or associated with your outcome following surgery. So the next question is, well, what causes the low VO2 peak in preoperative patients? Now, the most obvious ones are going to be the disease itself, particularly for certain types of diseases like heart disease and lung disease. But also if you think certain diseases like bowel cancers, which you're going to have possibly intra-abdominal surgery to remove, well, there's association between bowel cancer and things like smoking. There's also association between smoking and poor fitness levels. So it's kind of like a complex relationship between these things. And there's also like lifestyle factors are going to play a part as well. So diet, low physical activity, smoking, all of these things, if they may be predictive of the disease, but they also might be predictive of having low fitness levels as well. But finally, the one that we're going to think about is the treatment. So the treatment is, it might also have an impact as well, right? Because if the certain type of treatment you're on also impacts your fitness, then that could have a negative impact because it impacts your fitness, and maybe that's also going to impact your outcome following surgery. And this is the thing we're going to look at now. So, and specifically, we're going to look at chemoradiotherapy. So, this is a fairly recent body of evidence that really only started in the last sort of 10 years or so. And people started to think, well, can actually chemoradiotherapy have an impact on people's, physiology? And then if those same individuals that are having the chemoradiotherapy are then going to go for surgery, can that then have a knock-on effect? And so in this study here by West, which is a group that I used to work with a little bit, they did this great study where they were looking at to see whether what was the effect of chemoradiotherapy on people's fitness level. So it's fairly small. They just took 12 people who had rectal cancer, and then they completed a sort of standard 5-week course of neoadjunctive chemoradiotherapy. And then they looked at their VO2 peak and then other variables pre and post the chemo. So they were just wondering, does chemo impact your fitness? And then the question is, well, why would chemotherapy impact your fitness? And you may be familiar with some of these things, but chemoradiotherapy affects so many different parts of your body. And so the ones that might relate specifically to fitness, if we look at this sort of figure of a human and then the titles on the right-hand side, we've got peripheral neuropathy. So this is the kind of how well your nervous system is working in your periphery, so your arms and your legs. So chemoradiotherapy can start to impact this. So you can imagine that if your nervous system isn't working quite so well in your extremities, then this might have a knock-on effect on your ability to do exercise. There's also in the red pulmonary fibrosis. So this is a lung problem where you get stiffening of the lungs, which might influence ventilation and diffusion in the lungs, so that impacts your ability to take in oxygen. There's also cardiac implications as well, so it can cause ventricular failure, so it can impact cardiac output. It can also cause coronary artery disease over a longer period of time, hypertension. So you can imagine these are all possibly going to influence perfusion, so your ability to deliver that oxygen that's already in the blood. So if you're under a regime of chemoradiotherapy and it's going to impact some of these things or more, maybe that could have a knock-on effect on your fitness. And this is what they found. So these are the results from the West study. So we've got on the left-hand side the different variables. So the top two oxygen consumption at anaerobic threshold. The next two are VO2 peak. So possibly ones that we're interested in if you're thinking about looking at this population for your study. The next one down is oxygen pulse, which we've measured and you're going to have in your file. So if you're interested in this, might be a really good rationale to look at something slightly interesting like oxygen pulse for your assessment. And then finally, I've highlighted it because another variable that you have access to in your assessment, which is VEVCO2, which is in red. And what you can see from the study is we've got a baseline measurement for each and then a post chemoradiotherapy measurement. Then there's the difference. And then finally on the far right hand side is the p-value statistics. And what you can see is if you look at VO2 peak, is that VO2 peak represented both in absolute values and also relative to body mass decreased over the course of that 5 weeks of chemoradiotherapy. Significant decrease in VO2 peak. There's also a significant decrease in oxygen pulse. And oxygen pulse is this kind of proxy marker of cardiac output. So well, more stroke volume, I should say. A bit of a marker of stroke volume. Whereas this VCO2, there was no difference following the chemoradiotherapy. This is the kind of thing you can use to try and make a rationale for your study. You could potentially say, within our groups, I'm interested in studying whether the groups are different with regards to VO2 peak, and then potentially, investigate an oxygen pulse to see whether that has a role in our population. But you probably won't want to look at VCO2 because at least with regards to this, the evidence suggests that it doesn't change. However, you might even be able to use that as a reason to study it because you could say, previous studies have shown no change in VCO2. However, in other populations, it seems to be a really poor marker of fitness, and therefore I'm going to look to see whether it's different in my population. So you could potentially do something with it. But the main thing is to say that VO2 peak decreased, this marker of stroke volume oxygen pulse decreased due to these 5 weeks of chemotherapy. So amazing. So this is a treatment that's helping these individuals on the, generally, it's required, but it's also having huge negative implications as well. Now, I want to sort of highlight this further the reading because it goes much further than this and it gets really, really interesting. So I would really recommend, if this interests you, to read these papers. And I'm just going to talk you through some of them sort of major kind of studies and major findings, if you like, of how this progresses. Because what that initial study by West showed was that fitness can be impacted by chemoradiotherapy. But there's still lots of other questions which are like, well, once somebody's had chemoradiotherapy and they have a reduction in their VO2 peak or their fitness levels, does that impact survival? And this middle paper by Jack et al. Looked at that. So does the change in fitness due to chemoradiotherapy impact the survival following cancer surgery? Right. The next one looked to say, well, if people are getting a reduction in their fitness due to chemoradiotherapy, if we exercise train them at the same time, can we maintain their fitness level or reduce the decrease in their fitness levels? So essentially, let's put people under physical training program whilst they're having the chemoradiotherapy. Can that reduce how much of their fitness they lose? And that was this study here, so the one by West, 2015. And then finally, and a really interesting one, is, well, if that happens, if we can reduce the drop in their fitness due to chemoradiotherapy, why does it happen? And this final study, which is really exciting, suggests that maybe it actually reduces or increases tumour regression. So it actually might improve the treatment by making people exercise during chemoradiotherapy, which is incredibly exciting kind of finding. So the reason I've not gone through these papers in any sort of depth is because if you want to study this population, this is where I would focus my reading, because you could come up with some really interesting questions for your assessment. Right. Finally, so in conclusion, CPET so exercise testing is a useful tool for predicting surgical outcome following surgery. The markers that you're familiar with, the stuff that we've tested in the lab, are the same variables that have been used in hospitals across the world to try and predict this risk. And then finally, the stuff that we introduced just towards the end is this idea that some treatment strategies might have a negative impact on fitness, particularly chemoradiotherapy. So it's a treatment strategy, it's needed, it's the primary treatment or a primary treatment for that particular problem, but it has a negative impact on physiology. And then some of the newer bits and pieces are suggesting maybe through exercise testing we can start to do something about this. Why is it important to you? Your pre-op patients, the patients population that are available on the now, are exactly the same as that West 2014 paper. It's not the same people, but the same condition. So they've been diagnosed with locally advanced resectable rectal cancer. So resectable means it can be cut out. And the values that you have are all post-chemoradiotherapy and prior to rectal cancer surgery. So you'll be looking, your idea if you're going to use this population is to say, well, what physiological changes have happened due to the chemoradiotherapy, which has potentially caused that reduction in VO2 peak in comparison with the control population that haven't undergone chemoradiotherapy. And there's a free to access paper that's kind of a review on this area if you're interested in it. So thanks ever so much for listening, and I'll catch you next time.